to start this, and that's unfortunately as far as I go when it comes to my Spanish. So please forgive me. I'll try to do better next time. My name is Sergey Motov. I'm from New York, United States. I'm an ER doc. And before I start, I just wanted to express my greatest gratitude and appreciation to Doctors Alvarez, Mix, and Aguilera for extending the invitation so I can be part of this amazing conference. I'd like to thank Department of Emergency Medicine and University for making this whole thing possible. I want to thank each and every one of you for being here today. So once again, this conference is a great success. And I should probably put a plug for EMRAP for broadcasting this beautiful conference worldwide. Now, I'm super excited to be here for the three reasons. Reason number one, I enjoy talking about ED pain management because that's my passion. Number two, I like using NSAIDs for pain control. But more importantly, number three, I like to talk about the dark side of the NSAIDs, or danger of NSAIDs, or so-called some of the misconceptions of NSAIDs. As far as the financial disclosure goes, I've recently had a chance to co-author a book, tiny little book called Pain, pocketbook from Tarascan Pharmacopoeia, and according to the contract, I'm eligible for royalties, but I've yet to receive any. So let's talk about NSAIDs. I'm almost certain that all of you here will agree with me when I say that NSAIDs are by far the most common class of drugs that are prescribed worldwide for pain control, for fever, for inflammation, and most importantly for us emergency room physicians for managing a variety of acute and chronic painful conditions. They come in all shapes and forms. They can give even orally, rectally, parenterally. We can use them topically. We can use for all ages, and it seems to be very, very effective, specifically for mild to moderate pain or to moderate to severe pain if you use them as an adjunct to something else. Now, just to remind you, within the NSAID as a class, there's a subgroups. We're not going to go over them, but why is it important from clinical perspectives? Because if you have a patient who comes in and tells you, I twisted my ankle and I've been taking ibuprofen and it doesn't work, you're not supposed to be giving them naproxen. Why? Because it's the same group. So switch them to different subgroup class, such as diclofenac. It may work. So we use this table for NSAID rotation. It's very good. Another thing, as you remember from pathophysiological aspect, the way that NSAIDs work, based on their inhibitory activity towards COX enzyme 1 or 2, they can be divided into selective NSAIDs, such as COX-1 selectives, COX-2 selective, or non-selective. Why is it important? Because we all know, that more COX-1 selectivity you possess, more insult to GI tract you would have as an NSAID. Contrary, more COX-2 selectivity you have, you're probably going to affect your heart. All right, now let's talk about the dark side and danger. Why are we actually talking about NSAIDs today, since it's the most commonly used class of medication? Well, it just so happened there's a great deal of literature piled up over the past 10 years that clearly stated that the risks of serious gastrointestinal side effects such as acute gastrointestinal hemorrhage, acute renal failure, acute cardiovascular issues such as acute coronary event known as a myocardial infarction, or worsening congestive heart failure are directly related to a dose of NSAIDs, and on top of it, to a duration. So make it very, very simple. Higher the dose, more side effects, more risk of having GI bleed, heart attack, worsening CHF, or knocking off your kidneys. There's a great deal of literature that's showing there's a direct correlation between a relative risk of having those serious side effects and dose. Here's an example. Pooled data analysis with respect to relative risk of all the NSAIDs when it comes to GI risks doubles or even triples for COX-1 selective NSAIDs, doubles for non-selective, and even gets quadrupled for COX-1 selective, such as piroxicam. And one of the worst offender, which is not represented on this diagram, is ketorolac. Relative risk of ketorolac causing acute GI upset is about 24. All right? When it comes to kidneys, when it comes to cardiovascular offset or side effects, as you can see, almost every single NSAID have some issues with the heart. They are causing, for the long term, there's a relative risk of causing a heart attack. All right? Ibuprofen causes, naproxen is probably the latest one, or the easiest one to tolerate, but all COX-2, they have notoriously known to cause thrombotic events, such as MIs. When it comes to kidneys, pretty much every single NSAID, when given in a high dose, either double or triple the side effect when it comes to causing acute renal failure. So they're not really safe all of a sudden. Now, higher risk related to higher dose. Patients who are taking high dose of NSAIDs are 28% higher of developing acute cardiovascular side effects such as MI. They're 104% higher to develop risk of acute gastrointestinal bleeding, and they're about 35% higher of developing acute renal failure. Now, I love numbers. I'm going to show a few more numbers, and I promise I'll stop. This is specifically for the United States. As some of you may know, the country is going through the worst opioid epidemic crisis we've ever known, and because of it, rates of NSAIDs went up. For the past 2 years, went up by about 11 to 15%. It's a huge number. If you get 320 million people living in the United States, it's a big number of increasing prescribing for the NSAIDs. Now, this is the United States numbers, but I'm almost certain some of you will find this very applicable to you as well. 80% of all prescribed NSAIDs, such as naproxen, ibuprofen, or ketorolac in the United States, are prescribed at the highest allowable dose. All right? 8% of patients who are given prescription for NSAIDs take more on top of it because they believe the pain is not controlled. 38% of patients who are given prescription for NSAIDs are taking over-the-counter medications in the United States, over-the-counter NSAIDs. And 33% of patients who are taking NSAIDs believe their pain is so severe that they need to take more NSAIDs. A little more, 94% of doctors, not only emergency physicians, doctors in the United States do believe that NSAIDs should be given at the lowest effective dose for the shortest possible course. However, 20% of them are prescribing NSAIDs at the highest allowable dose. All right? 15% of physicians prescribe NSAIDs at the highest allowable dose to patients who are taking over-the-counter NSAIDs. 44% of patients who are taking over-the-counter NSAIDs taking in excessive dosages. And lastly, 92% of physicians in the United States do believe that it's very, very important to talk to patients about the risks of NSAIDs before they get prescribed, but only half of them do. All right? If this is not enough, in the United States, about 100,000 patients gets admitted to the hospital on an annual basis due to side effects related to the NSAIDs. 7,000 to 8,000 patients die every year due to side effects related to NSAIDs. And all of a sudden, NSAIDs become not such a good drug after all. I know it sounds fairly depressive. But there's a tweak, and there's a caveat. As we all know, NSAIDs are AAA agents. They're antipyretics, they're analgesics, and they're anti-inflammatory agents. But there's a one thing that NSAIDs as a class have, which is very, very important to talk to me, and I'm super happy that I can do this today. NSAIDs as a class possess a ceiling effect. And making things even worse, they have two ceilings. They have analgesic ceiling, and they have anti-inflammatory ceiling. Let me put it in perspective. Analgesic ceiling, this is a pharmacological phenomenon that implies after a certain dose is achieved, any further increase in the dosages of NSAIDs will not result in additional analgesia. No matter what you do, there is no more pain relief. However, higher the dose, you're going to get to the anti-inflammatory ceiling, which is usually limited by onset of toxicity, which is usually limited by the maximum allowable number of pills you can prescribe to a patient per 24 hours. So based on this, as you can imagine, analgesic ceiling dose is significantly lower than anti-inflammatory dose. And for us, ED physicians and non-ED physicians, anyone here in this room, we ought to prescribe NSAIDs within the analgesic dose. This is a paramount. This is an example how ketorolac works. After 10 milligrams of ketorolac is given to a patient, you can go 15, you can go 30, you can go 40, technically up to 60. You would not make any additional analgesic difference. However, when you hit about 40, the anti-inflammatory properties of ketorolac go up high. And if you remembered what I told you, rate of GI upset is the highest of ketorolac. So there is no difference between 10, 15, and 30 when it comes to analgesia. So the analgesic ceiling of ketorolac is 10. When it comes to ibuprofen on the bottom graph, there is no difference between 400 or 600 up to 6 hours if you give it to a patient who just recently had a tooth extraction. Analgesic ceiling dose for ketorolac per dose, for ibuprofen, it's 400, not 6, not 8. It works the same. If you go higher, you're going to kick into this anti-inflammatory zone, which is associated with the rate of side effects. One thing from clinical perspective I want you to be aware of, that there is actually difference between low-dose NSAIDs and high-dose NSAIDs when it comes to managing pain. All NSAIDs follow linear kinetic pattern, which means higher the dose, longer the duration of action. While I understand that we all, as ED docs, we aim towards relieving pain instantaneously, and we're hoping that analgesic will last as long as it possibly can. When it comes to NSAIDs, it's a very tricky situation, slippery slope. You kind of need to weigh in the benefits of long-lasting duration of analgesia versus side effects that can be potentially detrimental to patients' well-being. What's the difference? About an hour and a half or 2 hours between 10 milligram of ketorolac to 30. 2 hours is a big number, but if that number will cause GI bleed, I'd rather go to the lower dose. All right? Now, this is the most important part of my talk. In a setting of acute pain, musculoskeletal, visceral, somatic, when you consider giving NSAIDs, the degree of inflammation does not require a full anti-inflammatory dose of NSAIDs. All right? The NSAIDs given within the analgesic ceiling dose will be perfectly fine and perfectly capable of taking care of this inflammation in a setting of acute pain. And this is the most important concept. For that very reason, next time, today, tomorrow, for the rest of your life, you ought to see a patient with acute painful condition who has some component of inflammation. Consider giving him the smallest dose, analgesic ceiling dose, instead of giving him the largest one. All right, so it's good to talk, but let me show you some of the evidence. Now, ibuprofen, my favorite, probably one of the safest on the market when it comes to NSAIDs, given orally and given rectally. In the United States, it didn't work well. Now it's in Australia, intravenous form of acetaminophen. Make it story short. No matter which route you choose, analgesic ceiling dose of ibuprofen is 400 milligram per dose. If you send patient home, it's 403 times a day, which is about 1,200 milligram. Not 600 Q6, not 800 Q6. It's 403 times a day. How do we know it works? On the bottom, there's a reference. 2 studies, actually 3 studies. Patients underwent tooth extraction, wisdom tooth extraction. They all were given to 400 milligram of ibuprofen, 6 or 8. At 6 hours mark, there were no difference in analgesia. 400 did just as good as 6 and 8. So 400 for ibuprofen. Naproxen. This is interesting. If you look at the right part of the site, this is the naproxen formulary that we prescribe in the United States, prescription-wise. 500 milligram twice a day. To the left, that's the over-the-counter naproxen that's available to patients or people. It's 220 milligram per dose, given twice or no more than 3 times a day. So what is the analgesic ceiling? Well, according to the Cochrane systematic review, when it comes to postoperative pain and acute musculoskeletal pain, the analgesic ceiling dose for naproxen is about 250 per dose, not 500. Why? Because the number needed to treat when it comes to 220 milligram and 500 milligram of naproxen is essentially the same. Number needed to treat when it comes to NSAIDs implies that there is a certain percentage of patients who will have at least 50% change in pain score at 6 hours mark. So if you give somebody 220 or 500, all of them will have exactly the same change in pain score at 6. So 220, I would probably go. It would be the safest way to go with naproxen. Ketorolac, 10 milligram. That's what it takes for ketorolac to work as an analgesic. 10 milligram per dose given orally, rectally, intramuscular, or intravenously. There's a great deal of data comes from the cancer literature that clearly showed 10 milligram given IM provided same analgesia as 15, 30, 60, or 90, up to 6 hours. There's data from surgical literature that showed that 10 milligram of intravenous ketorolac resulted in similar amount of pain reduction at 2 hours mark as 30 milligram of intravenous ketorolac. We did a study, my group just recently, where we compared 10 milligram to 15 to 30. If we were able to show that up to 2 hours for the short-term analgesia in the ED, ketorolac at 10 milligram works just as well, just as good as 15 and as good as 30. Now, when it comes to oral route, it's a little trickier. I personally don't like use oral ketorolac. Ibuprofen is much safer, but if you do use it, it's about 10 milligram up to 4 times a day, but I would probably go 10 milligram twice a day. 10 milligram ceiling dose for ketorolac. Diclofenac. Great deal of adult literature postoperatively in acute musculoskeletal pain clearly states that 50 milligram is the analgesic ceiling dose for diclofenac given per dose. 50. Number needed to treat from 50 milligram, it's exactly the same as 100 milligram. 25 works about as half as good as 50. So 50 milligram, PO, PR, IV, or IM. This is your dose. All right? Now, ketoprofen and dexketoprofen, there's no really good data out of emergency medicine literature. There's the data from the surgical literature. And for ketoprofen, the analgesic saline dose is 25. 25 milligram per dose will have a number needed to treat of 2. 100 milligram per dose will have a number needed to treat of 2.1. 50, 3.3. 25 is way to go. For dexketoprofen, 12.5. Not 25, not even 50, 12.5 milligram. That's what the analgesic saline dose for dexketoprofen is. Data comes from the general surgery and dental surgery with a similar number needed to treat between 12.5 and 25. Lowest effective dose within the analgesic saline. Now, this is one of the things that I'm regretting immensely. We don't have this beautiful medication in the United States. And I want to thank Dr. Alvarez for providing this beautiful picture. In the United States, I couldn't even Google it. I couldn't find the image of metamizole, which is actually a crime. Analgesic saline for metamizole is 500 milligram per dose. Not 1 gram, not 2 grams, not 2.5 grams, 500. And how do we know? Well, the Cochrane systematic review clearly showed that 500 milligram will provide acceptable pain relief defined as a change in numerical rating scale of 50 or greater at 6 hours mark in 75% of patients. Patients who comes to the emergency room with tension headache, who were given 500 milligram of metamizole or 1 gram of metamizole, had the same change in pain score up to 4 hours. I may bump a little higher for renal colic patients, but 1 gram works just as good as 2.5. But once again, in order to be safe and effective, use the lowest effective dose, which is 500. Well, let me go back if you want to take a picture. Sorry. Now, the last one is a meloxicam. It's not widely used. It kicks in late, takes forever, and it has a fairly malignant side effect profile. But if you ought to use it, single dose, 7.5 milligram per 24 hours. I would not even push for 15, 7.5. So, all right, if I'm going to summarize all this, once again, the analgesic saline dose is the lowest effective dose of NSAIDs that will greatly take care of patients in acute setting. Patient with acute pain, not chronic, acute. Now, you may rationalize and say, well, you know what? We work in an emergency room. We give 1 dose, rarely 2, as you all know, because we spread NSAIDs every 4 to 6 hours. In DD, how is it even possible that 1 single dose, let's say we're going to give higher than you just told us. What if we give 30 milligram of ketorolac instead of 10? What's going to happen to a patient? Well, there is a data, apparently. The question is whether or not can single supra-analgesic dose of NSAIDs, single, cause harm. Let's look at emergency medicine literature. One of my favorite studies was done in 2005. Dr. Singer draw bloods from 20 emergency medicine residents. Imagine you come for the conference and doctor tells you, everybody roll your sleeve up, I'm going to get a blood. After that, all the residents had their bleeding time checked. And after that, they all received 60 milligram of IM ketorolac. What are they in the conference? Everybody gets poked. All waited 4 hours, and the bleeding time was repeated. And the results showed that bleeding time went up from 3 minutes, the all presumably healthy residents, to 5. Now imagine if somebody has a coagulopathy, inherited bleeding disorder. That 2 minutes difference turns into 10, 20, 30, and they will bleed, and they will bleed, and they will bleed. Single dose of IM ketorolac increases bleeding time by 67% in healthy patients. Now, Gallagher in 1995 looked at pediatric patients who underwent tonsillectomies, and they all received perioperatively, right before the surgery, 30 milligram of intravenous ketorolac. And the study showed that 10.1% of patients bled in a PACU, in the recovery room after surgery, to the level that they were taken emergently to the OR for re-exploration and hemostasis. 10% of patients who received a single dose of intravenous ketorolac at 30 milligram bled significantly and had to be re-explored. And lastly, my favorite study, a 32-year-old gentleman who underwent, let's say, ambulatory surgery, same-day surgery, went home with a prescription for ketorolac, 10 milligram, 4 times a day for 5 days, which is what usually we do in the United States. He started having a little bit of chest pain and cough after he took 3 pills. When he took 4th pill, morning following day, he went to the bathroom, brushed his teeth, he started having hemoptysis. He comes to the emergency room, he get a CAT scan, shows diffuse alveolar hemorrhage. Patient took 40 milligram throughout a 24 hours mark of oral ketorolac. He bled into his lungs. He did well. But this is just to show you, healthy people with a supra-analgesic dose can have complications. So time is up, and I'm going to summarize it. Look, I don't want to scare you to death. As I told you before, my second reason I enjoy doing this talk, I love NSAIDs. I know they work, and we all know they work for certain conditions, for certain patients. But remember, patients with pre-existing conditions may not do well. But most importantly, this is once again message, from now on till for the rest of your lives. Every time you're going to consider giving NSAIDs for patients with acute pain in the emergency department, utilize analgesic ceiling dosing regimen, the lowest effective dose that I showed you that will take care of the patient's pain. And that analgesic ceiling should be honored in the ED, and it should be honored when you send patient home with a prescription. And my final words, always consider prescribing NSAIDs with the lowest effective dose for the shortest effective time. You'll be successful, your patients will love you, and you will definitely avoid having all these major side effects. This is me. I'll take questions online if you have to. Muchas gracias. Thank you.